Welcome to our Critical Care Public Forum on Healthcare in Newfoundland and Labrador. We're broadcasting live from the Bruno Centre on the campus of Memorial University.
And for the next half hour on Here and Now, you can watch us. I think it's going to be a fascinating discussion. But this is going on for 90 minutes. The first half hour from 6:30 to 7 Island time on television. And then afterwards, from 7 to 8, we'll continue online, cbc.ca/NL, our Facebook page, and on our YouTube channel.
And if you're not here in person, you have an opportunity to have your voice. You can leave comments on the Facebook page for CBC Newfoundland and Labrador. And we're focusing on solutions to the many issues in the healthcare system that we've been talking about over the past couple of weeks with our Critical Conditions series. So that's what we're looking for from you. Do you have ideas? Do you have suggestions? What might make things better? Because Anthony, I think there's no argument that we've got some problems.
There certainly are problems, and we want to talk about those problems, but also, as Ramona said, the solutions.
All right, so let me start with Debbie Forward, who is the president of the Registered Nurses Union of Newfoundland and Labrador. Thanks so much for joining us.
Pleasure to be here.
Why don't you kick it off? You're not shy. Throw out one solution that you think could make people in Newfoundland and Labrador possibly healthier, definitely happier when it comes to their medical system.
Well, access to healthcare I know is a challenge for many people in this province, and increased utilization of nurse practitioners. We have many of them right now in Newfoundland and Labrador. I think about 115 positions right now, and I think there's greater capacity to utilize them in different areas, different sectors of healthcare, increasing them in what we call primary healthcare, which is the first point of access to the healthcare system, complementing family physicians and other providers. And we've seen government move in that direction, and I think we need to see more of it to make sure that people have access to a healthcare provider when they need it.
And so for the average person, what kind of difference could that make, having more nurse practitioners in this province?
Nurse practitioners are advanced practice registered nurses, so they're educated at the master's level, and they have capacity to diagnose, to treat, to order tests within their scope of practice, provide treatments, so they can complement other providers within our system. So in what we call the primary healthcare system, or in the community setting, nurse practitioners working with a family physician, with other registered nurses, or with social workers, pharmacy, you are able to access a nurse practitioner for many ailments that you might have as an individual. For example, they can treat people with infections, and people with sprains and strains and broken. They can order x-rays if you think you're broken your ankle. So some people don't have access to family physicians right now, and complementary providers like a nurse practitioner can help fill those gaps in the system, but they can also provide specific care. It's not just about filling gaps. It is about having access to those providers when people want to make those choices.
Well, it will be interesting to see if members of the audience agree with what you're saying, that it could make a big difference to have more nurse practitioners. We've heard from a lot of people who wrote into us at mystory@cbc.ca, and in fact, several people have said, let's use more nurse practitioners in this province. And also, worth noting, the province of British Columbia is going to bring in an extra 200 nurse practitioners. So that's one issue on the table. Thank you very much for kicking it off. You're brave.
You're welcome. Let's get it going.
All right, speaking of getting it going, let me introduce you now to Stephanie Lushman, who is an advocate for young adults who've gone through cancer. Hi, Stephanie.
Hi.
So can you really quickly tell us about how serious your case of leukemia was?
Quickly. Well, I was living abroad in South Korea, teaching English as a second language when I had a lot of random symptoms that I didn't put together: large bruising, bleeding from my gums and from my nose and many other places. Just cuts would not stop. And the bruises were about the size of grapefruit and very, very dark, and all over my legs and thighs. And when I went to the doctor, they got a blood test for me, and I had to go to a larger clinic, and then they diagnosed me with acute myeloid leukemia, AML leukemia, and they said that at that point, 93% of my cells were considered baby cells, which is kind of how leukemia works. And 93% out of 100, when you're doing a test, is great, but not when the test is for a blood cancer. So they had to. I was diagnosed on a Thursday, and they gave me the option. The hospital in Korea said, we're going to start you on on chemotherapy this Saturday, or you need to be on a plane to Canada.
Wow. And so you did have to come home, and it was life and death, right?
Yes, I started chemotherapy the week I got there on a Sunday. I started maybe that Wednesday. They did the test extremely quickly, and yeah, it was urgent.
In 10 words, because we'll be able to come back to this, what has your experience of the healthcare system been as someone who's gone through a life and death illness?
Honestly, it has been very positive, and I'm here today, standing here in remission, thank God, and able to talk about this sort of thing openly. That's way more than 10 words, I'm sorry. I'm doing well. I was taken care of.
That's so interesting because we've heard a lot of complaints, right? All right, let me throw things over to Anthony now.
For many of us, I think the face of healthcare are doctors like Dr. King here, because she's a general practitioner. For most of us, those are the people that we end up seeing. Thank you for being part of this.
Pleasure, thank you.
I'd like to ask you about something that Debbie Forward said a few moments ago. We hear a lot about nurse practitioners, and sometimes it's in conjunction with the notion that they can do a lot of things that you do, and that there's a bit of friction between both specialties, is not the right word, but both fields. Can you give me a sense of what GPs think about nurse practitioners?
It's a very challenging area because, as you said, the scope of practice is one issue, but also working together. For instance, it's the same situation that I have every day with specialists. I refer somebody to a specialist, and it's like, okay, who's going to do what? Who's right now looking after this patient? And am I looking after this part of the patient's needs and another person looking after the specialist? And that would transfer over to a nurse practitioner. There's certainly lots of work to be done, and we do need people using their full scope of their practice. So it basically, the bottom line is we need to talk and cooperate together and create something that will work functionally to the best of our patients.
All right, thank you very much. I'm going to introduce you to another doctor right now, Dr. McDonald, if I could get you to stand up right now. I appreciate that. We often also hear that some of the solutions for some of the problems we have with respect to cost is technology, and that's something that you know a certain bit about. You want to explain it, because you're very excited about this?
I am very excited. The eConsult program was started in Ottawa probably about 5 or 6 years ago and has worked tremendously well there. So a couple of us decided we would bring that here to Newfoundland. Now, what that is a way of getting specialist and primary care practitioners to talk to each other. And in the long run, what it generally does is it bypasses the need for a patient to go and see a specialist. So for example, let's say you come in and you see me as a family doctor and you have a terrible rash all over, and I look at you and I say, Anthony, I don't know what this is.
It's like you know me.
I can take a picture of that. I can put that on the eConsult platform, which is a secure server. I can send it off to a dermatologist who can look at it and reply back within a couple of days saying, I don't need to see Anthony, but you should do this, this, and this.
Do they get the referral?
Yes, they do. But they do it through the eConsult process, and therefore the patient doesn't actually have to travel. We did a study of 1,300 patients that have gone through this process. We managed to reduce the face-to-face consults by 60%.
So that would drive costs down in a major way.
Absolutely.
Does it also mean that specialists might be able to say, see more patients and say, actually, that person doesn't need a specialist?
It can. I mean, there can be a number of different responses. Sometimes the specialist will look at the information you sent and say, absolutely, this person needs to see me. Right. Get the regular consult in. Sometimes they'll say, no, I don't think I need to see them, but you need to do this, this, and this. And then sometimes the specialist will say, I think I should see this person, but before I do, make sure that they've had this test and this test and this test. So by the time they come to see me, a lot of that initial work is already done, and I don't have to spend extra time. I can get right to the meat of the matter.
All right, I look forward to talking more about technology. Thank you very much.
You're welcome.
You're watching a special edition of Here and Now. Right now, we're live from the Bruno Centre. Coming up after the break, we're going to get to some of your questions. Do check out our Facebook page, and if you've got questions about our healthcare system or observations, solutions, please send them in. See you in a bit.
Oh, boys, open your eyes. There's no need for a 4-year wait for anybody.
He looked at me and he said, but I didn't do anything. He felt like he was being punished, and that was pretty heartbreaking.
Because it's disturbing to see we're using restraints at times that they shouldn't be needed. And when I talk to staff, they say, Debbie, we just don't have the staff here.
And we are back after our short break. We're just getting things going here at the Bruno Centre on the campus of Memorial University. This is our public forum, our critical condition public forum, as we start talking about solutions to some of the many problems we have heard about over the past few weeks in our coverage.
Well, one of the big things we want to do tonight, of course, is get your questions, and they're already coming in a big way. Barbara Kent Bishop writes, rural Newfoundland desperately needs family doctors and nurse practitioners would definitely help, something we talked about before the break. And Joyce Hammond writes, I wonder why a person cannot access a new doctor when I believe per capita we have more doctors than other provinces. So we're interested to see who on the panel will volunteer to address those two issues.
And let me introduce another one of our panelists to you. She is Dr. Lynn Dwyer, the president of the Newfoundland and Labrador Medical Association, the president for a couple more days. Anyway, thank you so much for being here.
Thank you, Ramona, for inviting me.
So what's your dream ticket item, the one thing you'd throw out there that would make a difference for the people who are sitting here right now?
Oh, I don't know if I could have just one answer. I think that, certainly primary health care needs to be addressed. But overall, I think that we need to do a review of our healthcare facilities and services. As we know, our healthcare system is multifaceted, and we cannot continue doing healthcare the way that we have to. And I really think we need to review all of our services that we are providing to our patients.
And we'll talk about this a little later on, I'm pretty sure, about whether some hospitals in this province should close. But first, since we are talking about solutions and things that could help, there's a project that just unrolled this week that could make a difference for people in St. John's in terms of getting some access to GPs after hours, on weekends, even on holidays. So can you briefly tell us about that?
Yes, I'd be very delighted to talk about that. So May 22nd, last Tuesday, we opened an after-hours clinic here in the St. John's area. It's located at Major's Path. And currently we have 56 physicians participating in that, 28 family physicians, 28 emergency room physicians. This will operate every weeknight between 6 and 9 p.m., on weekends, 9:30 to 12:30, and on holidays. The 28 family physicians who are participating, their patients will be able to access this particular clinic. So if you want to know if your family doctor is participating in this, if you can access this clinic, you can go online to the lma.nl.ca and check to see if your physician is participating in this.
I just want to poll the audience here and see how many people never thought they would hear someone say that you might be able to see a doctor on weeknights, in the evenings, on the weekends, and even on holidays. Does that surprise anyone here? Yeah, people are nodding. All right, thanks very much for telling us about that.
Thank you, Ramona.
We actually have a question here from a gentleman in the audience, or it's a comment, and I know Jeremiah Perry has actually worked hard on this. He's written something, so I hope he'll read it in a lively kind of way. Jeremiah, what have you come up with?
Yeah, I'm coming from a different angle here, Anthony. I'm just going to read a comment out here.
All right.
Before you go through the doors of the health sciences, you see people smoking, eating, and drinking varying degrees of poison. When you go through those same doors, the very first sight is massive lineups at none other than the poison station itself, Tim Hortons. Shameful, shameful. The very foundation that is supposed to promote health, hypocrisy at its worst. Follow the lineup at Tim's, then go to the next lineup for the doctor. In my view, we are at a tipping point and headed for catastrophic genocide. All the negative statistics in the province point to the abyss, whether it be obesity, smoking, or drinking, on and on it goes. Not sustainable. We can throw all the borrowed money in the world at healthcare. No, not sustainable. Minister Hadji, the one before him, or the one after him, do not have the magic wand. It lies with me and you. Our economy should not be predicated on how many restaurants opens up or pizza parlors. It should indeed be measured by healthy people, healthy minds. Let us take a look at what we can do for the healthcare system, not what it can do for us. Perhaps instead of lining up at Burger King, at Tim Hortons or McDonald's, we should all be lining up for an educational program that takes us to the dietitian and to the local gym. This education can be and should be mandated by any government and promoted by the likes of CBC and others.
All right, thank you very much. Hopefully we won't have too many lawsuits as a result of those comments. Obviously, we hear this often in Newfoundland, Labrador, that we have to do something about our own behaviors. Who on the panel wants to address that? Because there is a serious point raised here. Debbie?
Debbie, forward.
Sure, we've been talking about people looking after their own health for a long time, and there's no secret that we're the unhealthiest population in the country in terms of obesity or alcohol consumption, smoking, all those things. And focusing on, health starts with focusing on the social determinants of health. It's not, it is about people having adequate housing, having access to good nutrition, having access to good education. I mean, those are social issues, so health starts there, and then we have to move out from that. And we all have to take some responsibility for our health. And it has to start with our children. And how do we educate our children around nutrition, activities, in terms of physical exercise, so that we get at the obesity issue? So how do we bring health back into our schools? And certainly one of the ways that we put out there in terms of registered nurses, we used to have registered nurses in schools. When I was a child, I knew who my school nurse was. I said hello to him, or mostly her, in the morning, and I saw that nurse if there was an issue. The nurse saw me before anybody else knew I had an issue. But we've taken those preventative people out of schools, and I think now even with mental health issues, addictions issues, drug issues, alcohol issues within our schools, we have to start back and putting those some health back in our schools with providers who understand health from a global perspective, because we can't depend on our guidance council and our teachers to teach health. It has to come from people who know health, and certainly registered nurses can be a part of that solution, and I think it's getting at the young people early.
All right, so much more that we will talk about as soon as we come back. We're going to take another short break. Keep those questions and comments coming in, please, on the Facebook page for CBC Newfoundland and Labrador, and we'll get to them as fast as we can.
Welcome back to our special forum here at the Bruno Centre, on Here and Now, and also online on our YouTube channel as well as our Facebook page. Hope you'll check us out there. We're getting questions coming in. I want to go right to one right now. This is a question from Pamela Russell, who says, I can't get a family doctor in Central NL. I moved here a year ago because I really need prescriptions, and it's just ridiculous. Things need to happen. I went to the hospital emergency room and I saw a doctor who was great about me being there. Another time I went there and I saw a nurse practitioner and she basically told me off for being there. What am I supposed to do? So who on the panel wants to go ahead?
All right. I'm going to dash over to Dr. Lynn Dwyer. And I just want to say that that is a common thread on some of the emails coming into my story at cbc.ca. Some people saying that they feel that they have not been taken seriously when they try to get help for their medical issues. And then someone comes along later and says, you really have a problem. Anyway, over to you.
Okay, so thank you for that question. Certainly, we, the Newfoundland Labrador Medical Association, we are aware that unfortunately we have patients that do not have family doctors. Based on studies that we have done, we estimate that it's between 10 to 13% of the population, so potentially 50,000 patients currently do not have family physicians. And we expect that that situation could worsen over the next couple of years as older physicians who have large patient panels retire. Last week, we did the Newfoundland Labrador Medical Association in conjunction with the chapter of the Newfoundland Labrador chapter of Family Physicians, College of Family Physicians, and the Discipline of Family Medicine, and we released a 10-year vision paper. And part of that vision paper is to address family medicine here in the province. And one of the things that we are saying is that we need to do a human resource assessment. We are calling on a review over the next year so we can identify how many family physicians we actually do need for the future. Currently, we probably have a little under 600 family physicians here in the province. But those physicians may not all be practicing full-time. They may be part-time, they may be semi-retired, they may be doing locums where they move from community to community, they may be in educational roles, they may be in research roles. So even though the number may be just under 600, they're not all working full-time. And this is an issue that we need to do a human resource management on.
And Anthony, you've got someone that you want to talk to right now.
I absolutely do. This is Jacqueline Cook, and Jacqueline, you have a specific question.
Well, we have an aging population, and although there are exceptions, cataract issues do seem to become more prevalent with age. And I was interested to see the wait times listed by Eastern Health. They reported that it's between 65 days and I think 113, if I'm correct, wait time from being diagnosed to actual surgery. And I'm wondering if this is giving an accurate picture. I have cataracts, and my date is 2020 for surgery. I'm wondering if it's showing the amount of time that people have to wait to actually get a diagnosis. When you're referred to a specialist, it can take a year or more. So what an individual has to do during the interim, I'm not sure.
So can I get the question, because we're getting close to the end here?
I'm so sorry.
Yeah, that's all right.
There was controversy over people having cataract surgery at a private clinic. These people would probably be pensioners and on fixed incomes. Why would people pay out of pocket thousands of dollars for a surgery which is covered under MCP if the system was as efficient as Eastern Health are saying?
All right, thank you for the question. Who would like to tackle the question on cataracts and the possible role of private medicine?
Okay. I will certainly, I'm speaking as a family physician and as president. I'm certainly not a specialist, and I'm certainly not in ophthalmology. But certainly wait times, we are again aware that this is an issue for our patients. And wait times often means the time that you have to wait to access that appointment. And it's the wait time to initially see the specialist and then the wait time for assessment after that. Certainly there has been a lot of media attention recently regarding an ophthalmologist wanting to set up an independent clinic on the West Coast and another ophthalmologist here in the city that there's been some concerns regarding. My understanding is that for a patient who wants to have cataract surgery done, When you have that surgery done during the hospital, the provincial government will pay for you to have a basic lens inserted. If you would like to have a better or more improved or a better quality, I think you can pay actually extra for that. But the base service of having cataract surgery done is covered, and as well as the lens.
And Dr. McDonald wants to weigh in on this as we wind this part of the show down.
Right. One of the benefits of using the eConsult program, and the more physicians we can get involved in it, the better, is that because we manage to get the answer for so many patients, and they don't have to see a specialist, that actually reduces the list, the wait times for the people who actually have to go. So the more we can use something like an eConsult program, the shorter wait lists will be.
So you're going to make sure that ophthalmologists are using this then?
If we can get some on, yes.
Okay. Was it a problem?
Well, we don't have all the specialties. We only have 28 different types of specialties, and some of those specialty groups haven't joined us yet for a variety of reasons. So we don't, for example, have rheumatology on.
Right.
And so those are kinds of issues. If we can get all the specialties working with us, then we have a much better chance of reducing the wait list overall.
Okay. Have to wind down the here and now portion of our special forum here at the Bruno Centre. Joined once again with my co-host, Ramona Deering.
Yeah, we need to say goodbye to our Here and Now listeners, Anthony, because we have to sign off the air. However, we don't want to lose them. We appreciate them staying with us. We're just getting started. We haven't even met all of our panelists yet because we've already been talking about so many issues. So if people want to stay with us, they can, right?
Absolutely, and I'd encourage you, if you're watching this at home on Here and Now, switch over to our YouTube channel. You can also check us out on our website and on our Facebook page, and we would really like you to keep those questions coming because we're getting a fair number of questions, actually. I'm trying to read them when I have a chance, and some of them are about very poignant and pertinent issues about our healthcare system. So for you listeners, viewers rather, on Here and Now, thank you so much for watching. Please switch over online and keep watching our special forum here live at the Bruno Centre.
Oh, boys, open your eyes. There's no need for a 4-year wait for anybody.
He looked at me and he said, but I didn't do anything. He felt like he was being punished, and that was pretty heartbreaking.
Because it's disturbing to see we're using restraints at times that they shouldn't be needed. And when I talk to staff, they say, Debbie, we just don't have the staff here.
Welcome back to those people who've been sticking with us on our Critical Condition Public Forum as we talk about some of the very serious issues in our healthcare system and hopefully some of the solutions that could make a difference. If you're just tuning in on CBC's Facebook page for Newfoundland and Labrador, welcome to this broadcast. We really invite you to share your comments and questions online with us. We'll keep going for the next hour, and we won't have any more interruptions, right, Anthony?
That's true. Thank you so much for joining us online, and I can tell by the number of questions we're getting that there are a number of viewers right across the province. I have an interesting comment from Nain that I hope to get to in just a bit. If you have any comments, whether it's about rural medicine, anything at all, please send in your questions, and we'll try to get to them just as soon as we can. And without any further ado, we have a great panel of experts, and we'll start getting to some of them right now.
Yeah, Anthony, I mentioned that we have not yet met all of our panelists, so let me introduce Rodney Goody to the audience here and to the people who are watching. Rodney is with the, I was going to say, yes, pharmacists, but you're not. You're with the Paramedics Association. There are two associations with the acronym PANL. Thank you so much for joining us. So you've got a lot to say about the role that you think that paramedics could play in helping to make our emergency rooms a little less gunked up with people who are desperately waiting for attention there. So tell me what the plan is, Rodney.
Yeah, so a number of different things that we're looking at and talking with government about. One is the expansion of advanced care paramedics. So right now, only St. John's and Corner Brook has advanced care paramedics working in the province. There is some that are starting up in Central shortly, but we want to expand that to allow them to work all across the province. So bringing that higher level of care right to the patient's door, right to the person's house, to the car accident scene, so they get a better outcome and better care right as soon as the medics get to the patient's house. We're also talking...
Just let me hold you there, because that was a lot of information. So walk me through this. I fall down in my home. I bump my head pretty hard. I'm able to call for help. What would happen in your vision of how this would work?
So with the advanced care paramedics, they're still working on the ambulance. They're bringing the higher level of care right to the door. So you're starting to get that pain medication, the cardiac medication. You're getting that right at your house rather than waiting until you get to the hospital to start to get that higher level of care.
But you wouldn't necessarily send an ambulance to my house, would you?
Yep, for that type of situation we might, but other situations, so another thing we're looking at would be community paramedicine. So this would be an expanded role, expanding the scope of practice for paramedics, whether it be a primary care paramedic or an advanced care paramedic. And so they'd be able to go to the person's home, maybe not for like an emergency call, but it could be for fall risk assessments. So assessing the person's home to see if there's anything that can be done to better improve the person's home to prevent a fall. It could be patients that have been in hospital that have been discharged, and so now the paramedics are going there to assess the home, assess the patient, in order to make sure that they are taking their medications appropriately, taking care of their wounds or whatever instructions they were given as they left the hospital, maybe IV antibiotics, wound care, so things that prevent them from having to come back to the hospital to tie up a hospital bed, an emergency bed, tying up physicians and nurses, and keeps them in their home, so it prevents an ambulance transfer of taking that patient to the hospital and then again back home. So
We associate paramedics so strongly with ambulances. So what would these teams be driving?
yeah, so it could be still an ambulance or it could be like an SUV unit. There's a number of different models that are being done right across the country. In Nova Scotia, they got a number of different community paramedic models. Some are in the rural setting where they're in isolated communities. Some are in urban settings where they're going to nursing homes, places that are frequented quite a bit by ambulances, paramedics, and treating the patients at the nursing home rather than taking them to the hospital, taking them out of their environment, and having to take them through the suffer of having to be brought into the hospital as well. So
that's something people in the audience might have questions for you about as they try to get a better grip on that concept, but it could make things better in our emergency rooms, right? All right, over to you, Anthony.
All right, we're getting a lot of reaction online, and we've heard a fair bit tonight about the role that nurse practitioners might play in helping us address some of the problems. This is from Natalie Coombs, and Natalie writes, "We have a nurse practitioner established here in our small town of Terrenceville, and it's working wonderfully. It cuts down on a lot of elderly people, such as my grandmother, having to travel 1 hour to get to the Buren Hospital for blood work when she's checked frequently because of blood thinner levels." So another comment about, successful comment or successful interpretation about nurse practitioners. I want to shift to another topic. As we have frequently covered on the CBC, cancer is a major issue in our healthcare system, and we're all getting older. Cancer rates in certain areas are increasing, and my next guest, guest with me right now, John Brooks, wants to raise this.
Sure, there's a couple of comments that I want to make. One comment, and then I do have a question as well. I'm a cancer survivor. I was diagnosed about 3 years ago, and I've gone through the system. I've had treatments. I've been a regular customer at the Health Science, and like the youth advocate, I can only have positive things to say. I recognize, of course, cancer is much more of a priority than other things, but I only have positive things to say from the manner in which I've been treated and the wait times, of course, again, recognizing the priority involved with cancer. But one of the things I guess I want to talk about here, and one of the things I've learned through this process, and I'm still learning, is to educate yourself. You have to constantly educate yourself. That doesn't mean going on the chat rooms and the internet. It means going to reputable medical libraries, getting information, knowing so that you can ask the proper question and so that you can be in the proper frame of mind to make those kind of decisions. I've been very fortunate in that the doctors that have treated me have recommended that. I think I called Ramona one day and told her about this. I went to there's a wonderful medical library at the Health Science. I'm a regular visitor there. I think I'm on a first name basis with the people now. But you've got to educate yourself as a patient. I don't know if anybody has a comment on that. If not, then I've got a question as well.
Why don't we bring cancer survivor Stephanie Lushman into this?
Hi.
Because to be in your 20s and diagnosed with a type of cancer that could take you away from this world, I don't imagine you knew a lot about anything at that point.
No, and I just kept ignoring my symptoms or pushing them aside as vitamin deficiencies, low iron, making me bleed. I'm uneducated about it, like I guess most people my age would be. And what you're saying is awesome, and I actually wish that I put more thought into it as well, and I hope that anyone listening is also taking it to heart as well.
Yeah.
So.
And you said you had a question as well?
Here's the question that I have. You know, I think there's two things really to, you know, to dealing with the wait times especially. And you know, as a cancer survivor, I've been fortunate. I haven't experienced wait times and I'm otherwise healthy, but I hear these horror stories about wait times. And it seems to me there's really two solutions. There's obviously the short-term solution, but what about the long-term? And I guess my question for any of the panelists, but in particular the doctor, is have we looked at solutions that other provinces in Canada have dealt with? How have other provinces in Canada dealt with the wait time? Surely this isn't just a Newfoundland thing. And on that as well, have we looked at those? Should we look at those? Should we look, for example, at the model at the Bliss Murphy Cancer Center, because they have an incredible amount of patients that go through. You know, have we looked at those sort of models, even a model from other countries where universal health care is in place? Have we looked at those sort of things?
All right, so let me just bring Dr. Lynn Dwyer into this conversation and preface it by saying that we've heard from the people writing into my story at cbc.ca that cataract surgery wait times are a real concern, as we've heard already this evening right here. The wait times for rheumatologists, they've been a huge issue for a long time right now. If you've got what's considered to be an urgent case of inflammatory arthritis, which means you're probably not functioning, you're only feeling pain, it's 18 months before you can see the rheumatologist. A 2-year wait at least before people can see neurologists. I could go on, but are there other models that might help us in some of those really sticky spots where people are suffering?
That's a very good question. I have to say that I'm currently not aware of what other provinces are doing with respect to screening and with respect to wait times, but I did want to just backtrack a little bit before I talk further about that, just to speak to your earlier comment regarding education. And you know, I really think it's important that our patients do educate themselves, and education allows them to empower themselves with respect to owning their own health care and being responsible for their health care. So I do encourage my patients, you know, to read reputable websites so that they are aware of their health conditions. So, you know, I encourage all patients to do that.
You're not stalling for time because there is no answer to how to fix this wait time problem, are you?
What I was going to say was, again, I think it comes back to, you know, here in the province we're looking at primary care reform and, you know, family medicine, and I think we really need to start with our healthcare system and start at the bottom and to build things up. And I think that a lot of issues that we currently have with respect to access and wait times is just even starting right at that primary level. The patients can't even get in the door to access their family doctor. So we need to start there, building our family medicine teams, working collaboratively with other healthcare members, whether that's with a nurse practitioner or a social worker. Oftentimes having a social worker in my office would be beneficial for addressing a lot of the issues that I deal with. But unfortunately, no, I don't have an answer as to what other provinces are doing.
Let me very quickly ask, would it help if we closed some of the dozens of hospitals we have in this province? You would have to spend less money filling them with medical staff and less money maintaining them.
I think, Ramona, rather than just cutting hospitals or closing hospitals or cutting services, we can't be doing that randomly. We need to do a review of our facilities and our services that are available here in the province and say, look, what is working well? Why is that working well? Maybe down the road, an hour or two down the road, let's look at that facility. Why is that one not working as well? And we really need to have an organized plan to move forward.
Okay. Anthony.
Dr. McDonough wants to weigh in on this topic as well. Doctor?
Well, I think one piece that we need to be looking very clearly at is the use of technology. How can we utilize technology in order to more streamline, make things more efficient, and reduce sort of the waste of times?
Are you thinking of a specific gizmo?
Not necessarily a particular gizmo, but there's lots of different things out there. I'm of course, personally interested in the e-consult program, which I know in the Ottawa area did reduce wait times and is in fact being piloted across Canada in a variety of different places. But that is just one type of using of technology. And there's lots of different things that we can be a little bit more efficient with. So if a physician is spending his time or her time on the phone, looking for pieces of paper, et cetera, waiting for things to come through the mail, if it can all be done electronically and you have it at the tip of your fingers, that can actually cut down.
And more time to serve patients.
Absolutely. And I think specifically using the e-consult program, let's get people out of the specialist office who don't need to be there.
All right, thank you. Now, I want to actually move things along a little bit with some of the online comments. So far, much of our forum this evening has concentrated on physical health. 2 comments here about mental health. One from Roxanne King. My son was sent to the Janeway 4 times, and 3 of those times were suicide attempts, and one in which he was saying he was going to do something, and he was sent home, and we were told it was because he didn't fit the criteria. Elizabeth Winters writes, it's Elizabeth Winters Rice rather, mental illness supports are a top priority for me. I've lost my adult son to suicide. It happened 1.5 years ago, and I know that there is a publicly stated focus on the significance of mental illness, but I feel that too much of the focus is on the administration factor rather than where it's actually needed. Our community has recently offered a 1-day clinic a week, and it's a start, but it's like putting a Band-Aid on a gaping wound. She goes on to write, our government needs to hire more psychiatrists for each region of our province. We have very limited psychiatrist visits here in Labrador. Is our government going to stop doing the paper chase and the public feeble awareness attempts and seriously address the needs for us here in Labrador? When will we have our own station psychiatrist here? Once a week open clinics simply aren't enough. Some of the comments that we're getting. Ramona.
All right, now I know that Debbie Forward wanted to respond to the wait time issue, but I'm sure before you get to that point, you can't skip over what we just heard. It's really, really disturbing, right, to hear what people are going through. We've heard from a lot of people at my story at cbc.ca that wait times for psychiatrists, a huge issue, a lot of people waiting a year or longer. So if you'd like to quickly respond to that, and then we'll talk about wait times.
Sure. Well, mental health is a significant issue for this province, and I think in particular, I certainly hear stories in terms of youth and young people and the challenges around that group, one group, and I also hear challenges around elderly in terms of them having mental health issues and how they get access to care. And I think, psychiatrists, are one provider around that, but I think there's opportunities around how can we utilize other individuals who are especially trained in mental health issues. How do we get at those issues earlier? And how do we use, for example, it doesn't have to be just registered nurses, but that's one example. How do we use a specialized, clinical nurse specialist in mental health? How can we have more of them in the system, which can support those individuals who just need that, the early help? And that sounds, I don't want people to take that the wrong way, but how do we intervene quickly so that we prevent other things from developing to be more serious issues, which then might need a psychiatrist? Labrador, I don't think we can talk about healthcare in this province without looking at the particular needs of people who are not just in Labrador, but rural and remote. We have to recognize how big our province is, how diverse our population is, and I think Labrador is a particular example of that. Their needs are different. We have different populations there, and it's an ongoing issue. They have access issues that none of us can even comprehend, because they have to travel such huge distances at extreme costs for what we consider as basic health care. It's a real challenge, and those are big issues.
In fact, I received an email late this afternoon from someone saying that they have had to change flights 3 times because their appointments with specialists they're flying out of Labrador to see a specialist in St. John's. Those dates keep getting changed, but they've had to book very expensive tickets to do that. All right, did you quickly want to talk about wait times?
Well, it's an age-old problem, and I think it's a problem across the country. I think there might be some models, but again, we also have to recognize our geography. And some of the wait times for some of the specialties, and this is my own, I don't have any proof of this, but my understanding of the system as a registered nurse, it's really hard to attract some of these specialists. And there's a shortage of them right across the country when you look at rheumatology, neurology, and we've been very lucky to have some, what I think leading the country people in those specialties, but there are shortages in those areas right across the country, and we're trying to compete as well. So we need to find efficiencies around using technology, making sure people are triaged properly, that people and triage is an assessment that is done, in terms of who needs the service fastest, And I don't think we've been as transparent around those processes as we could be, so people in the province understand why I might have to wait a year to see a cardiologist. And it's because the issue I have can wait longer than the person who might get in next week, because they're at risk, a higher risk than I am.
Are you referring to yourself? Debbie Forward is waiting a year
I
to
am.
see a cardiologist?
I-
But you're the head of the nurses union.
That's a pretty personal question, but yes, I wait. I'm a citizen. I might be a registered nurse, but when I access a system, I'm accessing as a patient. And you access a system as a patient. And I might have a lot of knowledge, but I lose all that when I access the system because I'm there as a patient. And yes, I have to wait. But I'm trusting that the proper assessment has been done, and I believe it has. I understand the system more than the average person, but I don't think that we've been really good at explaining to people about that process and why people have to wait, because that's what our public system too is built on, which I believe in, a public universal system where it is on a need-based versus ability to pay.
All right, thank you for sharing that information, and let me throw things back over to Anthony.
Well, when it comes to heart issues and having to wait, Andy Grant knows a thing or two. He wants to make a comment and then pose a question. Andy.
Anthony, I first wanted to say I'm disappointed the Minister of Health is not here tonight, because my question would be directed at him.
If he were here, what would you ask him?
I would say, first of all, that it's quite obvious over the last number of years that the consensus is that we have a system where the demand far outstrips the supply of the various services needed in healthcare. And I can't understand, nobody has given me an explanation why yet our government can't contract out certain specialist services to other provinces so that people who have time-sensitive ailments where they're deteriorating possibly to the point of no return, even death, could not access those services on an infrequent basis, depending on the availability of specialists here. But it would be, I think, a big step forward to shorten the queue and get these people the service they need rapidly, more rapidly.
Any idea as to why that doesn't happen? I think in certain specialties it does happen. Should it be happening more? Is that your...
Well, it may be happening, but I know people who are waiting for various surgeries and so on, various treatments, not just necessarily surgery. I used to be with the Arthritis Society, and I bet many people there who they'd be almost in tears talking about waiting to get to see a rheumatologist. And all the time they were waiting, they were deteriorating to the point where, in some cases, they may have even not recovered, not have passed away because of it, but they wouldn't have recovered from their need.
And your
invalids.
Your particular issue is a heart issue?
A heart issue, yes. I can't see why certain people who have major problems with heart disease can't jump the queue, if you want to put it that way, and go to some other province and have their situation looked after. Before, I mean, it's quite possible in some of their cases they'll die before they get the treatment. So I think that's pretty drastic. And I would love to hear the Minister of Health explain why that couldn't be done, not for everybody, but selected, justified cases.
Now, in the absence of Mr. Haggie, and I should point out that we did invite the Minister of Health to be part of this, and he was not available. Would somebody like to comment on the suggested notion of perhaps sending some patients from Newfoundland and Labrador to other provinces? Is that contentious?
Dr. Lynn Dwyer.
Okay, I probably won't be able to answer your question fully, but I'll give you maybe some thoughts. I mean, I think we're all aware of our current fiscal situation that we have within government, and I'm not employed by government, so I can't speak for government. I'm speaking as a family physician, and part of the reason why I got involved with the Medical Association was because I appreciate we cannot continue doing healthcare the way that we're doing it. And currently, I think our healthcare budget here in the province is like $3 billion. So I don't think that necessarily putting more money in is what we need to do. I think what we need to do is we need to look at what we are doing now and how we can be doing things differently. And whether, as Dr. Susan McDonald has already said, whether that's using e-consults. So maybe if I have a clinical question I used eConsult this past week. I had a question for a cardiologist regarding a patient of mine. So rather than putting that referral in the mail, I did an eConsult to the cardiologist with my specific question and concern for my young female patient. And I had a reply back within 2 days as to how I could better manage that patient. So maybe what we need to be doing is using our technology, the eConsult, or telemedicine for rural areas of the province. So maybe what we need to do is to be able to ask those questions as opposed to the patient being seen in person by the specialist, how that patient can be connected with the specialist without actually necessarily being there in person, and have some of those clinical questions addressed.
Let me just throw this into the mix, if I might. Just again this afternoon, I cannot express how many emails are coming in to my story at cbc.ca. Received an email from a person who really needed to see a rheumatologist. At that time was told it would be a 2-year wait. So they paid to fly to the United States because their condition was going to deteriorate, possibly within 3 months, to the point where they could never fully recover. So paid out of pocket, someone living right here in Newfoundland and Labrador. Anthony.
And of course, not everybody can afford to do that. I should mention to you that Mr. Haggie has agreed to be on the St. John's Morning Show tomorrow, so it's not as though he's gone into hiding.
Good, I'll be listening.
All right. Thank you very much, Andy.
Okay.
I want to get to some more of these comments that we're getting online. This is from James Wick, who says, I suffer from depression. It runs in my family. My son gets it as well. It doesn't help the province is currently in recession. That means more people out of work, financial duress, and stress. Federal transfers were supposed to be available to upgrade the provision of mental health services in this province. When will we see the results of that funding? Also, Victoria Morrison says, we should implement user fees for missed specialist appointments. I forget the stats on how much missed specialist appointments cost, but I do recall the figure is quite high. And then if the fees are not paid for missed appointments, that patient should not get a new appointment until that fee is paid. Pretty hardcore. Beverly Williams says, suggestions for savings, have doctors follow up with patients over telephone with the results of small tests such as blood work. In my case and many others that I've heard, having to make a follow-up appointment to see the doctor just to get results with a 1-minute call would take care of that. To me, it's a money grab big time, and it's really, there's no need for that. Hope you're enjoying this special forum. Critical Condition is the culmination of our coverage of some of the healthcare issues that affect our province. Also looking for solutions. A lot of you who are writing in online, I notice you're tending to look at what's wrong. I wouldn't mind seeing more of you write in with your suggestions about what is right. So please write us. You can watch us right now, as you are doing, on Facebook, on our YouTube channel, or on our website, cbc.ca/NL.
And Anthony, I'm surprised that we haven't heard to date a whole lot of talk about prevention. So let me put this question to Dr. Susan King. Do we have, Dr. King, a healthcare system, or do we have an illness system?
Well, we have a combination. There is preventative care that's done. Unfortunately, there is the burden of illness that saps up a lot of money and resources, and there's not an awful lot left over. And from the physician point of view, we spend the vast majority of our time reacting to somebody's illness or trying to sort it out to see what it is. One of the things that's been mentioned is the obesity and the lack of exercise, the lifestyle changes. And I really don't like it when people seem to be blamed for the habits that they have. We are all here, we're on our own pathway, and we reached where we are somehow, and people have different pathways. And the thing that I see is that a lot of people just aren't modeled, an active lifestyle. They don't have the opportunity to see what it's like to be active, to read stories, to eat meals around a table. There are a lot of people, children, who at supper is out of a box, out of a tin, and set and eaten in front of the television. That loss of family connectivity and the loss of a home-cooked meal. So something simple like, a movement that says, eat supper with your family once a week, or have Sunday dinner with your family once a week, and those things, and then go out and play.
Do you truly believe that if more people had supper with their own families, you would have fewer people visiting you in your clinic?
That's a bit of a stretch. But when you talk about mental health, we know the things that determine our mental health Exercise and diet have a huge impact on how our body can function mentally and physically. And connectivity, we all need to get together. But if you're sitting down eating, on a Chesterfield, we all do it. Everybody eats in front of the TV. Yes, I'm not saying it's illegal. But to sit around the table and just say, how was your day? How was your day? What happened with you? That family and that feeling of belonging and connectivity, which is so important to mental health, and building connections and playing with friends and just free play, go out to the park and things like that. So, but there's lots of people that wasn't modeled to them, so they don't model it to their children. And the hand that rocks the cradle rules the world.
All right, let me put that question to Rodney Goody. What do you think? Do we have a health care system here in Newfoundland and Labrador, or do we have an illness care system?
Yeah, I definitely think it would be a combination as well. More prevention needs to be done, but we do have more prevention needs to be done in order to prevent hospital visits. And, again, back to what I was saying before with the community paramedicine, that's one of the opportunities that we can look at in order to prevent patients from having to return to the hospital or to go to the hospital in the first place. In Nova Scotia, when their community paramedicine program started, within a year, the decrease of hospital visits was 23% actually. So definitely prevention is going to be one.
23% in decrease in ER visits?
Yes, that is correct. Yeah, in one particular spot when they did a study afterwards to see how well that was received in the area, that was the result that came out, was 23%. So
that could literally shave hours off the wait time for the people who are in ER, could it not?
Yes, definitely. Prevention, having the paramedics going in, assessing the house, assessing the patient, changing the way that they're doing things, and then that can ultimately prevent them from having to go to the hospital, and also be treated there in their home to prevent them from having to go to the hospital for that as well. And that prevention will definitely help with the wait times. So.
Wow, that is really interesting. All right, Anthony, I'll throw it back to you.
All right, interesting perspective here that I think a lot of the people who are gathered here at the Bruno Centre, as well as people watching online. This is from Samantha Randall, an American, and she writes, as an American that has an MCP card, it's the bee's knees. I haven't had insurance of any kind for over 2 years since I moved back, and she punctuates this with the very American, y'all got it made. So thank you, Samantha, for writing in. Now, my next guest here, Deborah Jackman, also wants to talk about something positive, and it has to do with psychiatric health. Deborah.
Yes. Somebody mentioned earlier about, what's needed in some parts of the province, like to go there, whatever. And I want a big shout out to Channel and the Peer Run Center, Recovery Center, and the Warm Line. It's saving a lot of people from having to go to the emergency, the assessment unit, because they're able to help with de-escalation, and their peers. They suffer with mental illness and mental health. And when you have that common ground, it makes a big difference. And right now, they're about to add another one more Warm Line person, so that's only 2, which I know I know they're working towards more. We definitely need that, and it is keeping people out of hospitals like myself, and I like that.
I do too, and I'm glad you're here. Thank you very much.
Thank you.
Right, preventive medicine, obviously a big part of what is important in terms, especially of finding solutions with the expenses of things and keeping people out of hospitals. Well, that's one way to do it. Ramona.
All right, I'm back with Stephanie Lushman, and as we've been telling people, she is a cancer survivor, a young adult cancer survivor. You really didn't get a chance to elaborate on this, but if you could quickly sum up for us. You said at the beginning of this program that you had excellent care. You're not hearing a lot of people say that tonight, right? A lot of people have a lot of concerns. So what shone for you in our healthcare system?
Well, when I think about the doctors, every single doctor, when I was first diagnosed, they sat down with me and my family, and they detailed the plan, and they talked about what the sickness was. I was flooded with information. Some stuff I didn't even read. I was so overwhelmed, and my family read it, and we were able to go into it educated. And that's so important, as this man was saying earlier, to be educated about it. Also, the nurses were amazing. Even the cleaning staff that came in, they were compassionate and understanding when it's like, hey, I threw up on the floor, I'm so sorry. They're like, don't worry about it, just get better. And it's like, that's amazing. It's fantastic. And it did so much to not only my physical well-being, but my mental and emotional well-being as well. And I think that's a big part of why I'm able to stand here and be so positive about it. It was a multi-tiered positive situation for me. There were negatives, and yes, it wasn't perfect experience for me. Like, you know, don't hire me, Eastern Health, don't hire me just to say beautiful things or anything, but.
Well, maybe they will now.
Yeah, there were some negatives, but honestly, there was just so much that I could say.
And just really quickly, you do have a concern about parking, right? And I think a lot of people could relate to that.
Yes, ma'am. I know that when I was really, really ill, for people that often go through chemo, they are outpatients during the, after you get your chemo, you go home and you kind of wait for your immune system to start failing. It's sucky, but it's for the best, I guess. But so when I was home, the cycle was I would start getting fevers usually. And so I'd be vomiting, I'd be a mess. And I couldn't move, I couldn't walk, so we'd have to go to the emergency or go to a clinic or something. So once we got to the hospital, as everybody here who's ever been to health science, if you don't have a sticker, you're parking all the way in the back. And so oftentimes it was my father who drove me, and I couldn't walk that way. There was no way I could walk it. So he'd have to leave me in the car, vomiting, crying, maybe out of it, and he'd have to walk all the way to get a wheelchair and then physically lift me up. And you shouldn't be, nobody should be lifting me up, and putting me in a wheelchair and bringing me all that way back. And it was just time and energy for both of us, and it was just a miserable situation, and it happened again and again. And I know I'm not the only person that has dealt with a diagnosis like that or dealing with that sort of treatment that has had that experience multiple times. And
what would you like done?
Yes, and what I would like done, I guess, during that short treatment time, not while I was an inpatient, but as an outpatient, and they know my case was not abnormal. It's what happens when you get chemotherapy. So for chemotherapy patients, to get a designated parking area and a sticker or whatever, just to be able to get closer and make my family and me personally. And what about people that have to drive themselves? If I had to drive myself, I would have rolled there. Like, I have no idea how I would have got to the front. I would have been like, Dad, just drive by and throw me out, you know? Like, I have no idea how I would have got in the hospital. So to have that designation, I know there's a petition going around online that I see pop up, and I'm always signing it and forwarding it, but so far nothing. And I think it desperately needs to happen.
Oh, Stephanie, thank you so much for sharing that. You're giving us just the tiniest glimpse of what it's like to be so seriously ill, right? And helping us relate. Yeah. All right, Anthony.
Facebook is really jammed with comments and questions. I've got a couple of positive ones here and then one that's a little more critical. Natalie Coombs says, great talk tonight, guys. There are bad things in our healthcare system, but we also have a lot of good stories as well. EMRs, PCAs, paramedics, and other healthcare professionals who do such a wonderful job. Nancy Way Chambers in the Big Land says, we have a wonderful nurse practitioner here in Lab West who is so thorough and excellent. We need more like her. Great care and great follow-up. Now the critical one, this is from Philip Lynch, and his question is, I want to know, why is it illegal for a person to pay for their own health care if they want to do so with their own money? I don't understand how this can be illegal. People have disposable income, and some people want to spend it on improving their own health. Why is this not legal? By the way, I am not saying we need to abolish universal health care. If you want to keep sending in those comments on our Facebook page, please do. It'll be there also at the end of our forum tonight for people to check out. And if you're in the audience here and you've got something you want to say, let me know, and I'll try to get to your question. Ramona.
All right, so that last point is one that has also come up in emails to mystory@cbc.ca. Some people saying, it's time to bring in user fees. We have an enormous financial problem in this province, and we have a very unhealthy population in general. So we just heard that last comment. Debbie Forward, you were saying earlier in the evening that you're a staunch defender of universal health care, but that gentleman was saying, listen, if I need it, why can't I just pay for it?
Well, I hear that comment a lot, actually. So our public healthcare system, our universal healthcare system, is based on need versus ability to pay. the comment earlier about user fees and people missing appointments, you know, I think rather than punishing people, which a user fee is a form of punishment, in my opinion, we need a better system of reminding people about appointments. What can we do to make sure people get to them or they cancel them in advance? When I make an appointment to have this nice polish put on my nails, I get a reminder by text 24 hours before, and I reply saying, yes, I will be there. I don't miss an appointment, or I call and I cancel. But in our healthcare system, currently we're getting letters, and if you happen to be away or misplace the letter, you might miss your appointment. So we need to use technology better around that. In terms of people paying, we only have so many people to go around, and that either be specialists or professionals, registered nurses, LPNs, physicians, other providers. We only have so many of them. So if I say, well, I can afford it, I think I should jump the queue, get to see someone faster because I can pay. But if I do that, it means that I'm taking up the time of someone who can't afford to pay because I can just pay out of my pocket, and I am jumping queues. But it doesn't mean that we improve our access. We improve access to the people who can pay, but what about the rest of us? Because I can't afford to pay for those expensive surgeries that cost $70,000, $80,000, $90,000, $100,000, because that's what people are paying in the US if you don't have insurance. And not everybody can afford insurance. Insurance is expensive. So, I mean, it's not as simple as saying, well, if I can pay, I should, because the rest of us, the 99% can't afford, and we're going to access that public system. There's only so many specialists. You know, for the person who's doing heart surgery, we only have so many people in this province who are doing heart surgery. So if you access it privately, guess what they're not doing in the public system is a heart surgery. If you need RNs to look after that person post-operatively, which you do, because it's not just the surgeon, it's the anesthetist, it's all the other people. If they're looking after the person in a private system, guess what they're not doing in a public system? Is looking after people in a public system. So people will go without. So we need to improve our public healthcare system, not go down a road where we're bringing in a private system. Let's just look to our people in the South. Someone wrote and said, you should be thankful. Yes, we should. There's still a lot of work we need to do. Let's do it together. But let's keep our universal healthcare system where it's based on need, not on ability to pay.
Lots to think about there.
Yeah, and
Listen,
certainly...
people are, sorry, Anthony,
That's
but
okay.
people are clapping. But are there people who would clap on the other side of things? Are there people who would prefer to pay so that they could get the treatment that they're looking for?
At least one hand went up in the
Yeah,
audience
one
there.
hand.
One
All right,
person
over to you.
who's be interested in that kind of situation. I'm joined now by somebody else who has some solutions to at least discuss with the panel. Lynn Green.
Good evening. I don't know about solutions, but I do want to say, it's funny, I'm following on Debbie's comments. I have 3 daughters, 2 who live in the United States, and if anyone knows me well, whenever I'm in Boston, I am always promoting the Canadian healthcare system. And so I feel almost embarrassed here that I'm saying anything maybe negative about our system. But my eldest daughter actually recently got diagnosed with cancer in the US, and fortunately she has insurance. Without that, it would have been a very sad situation. One of the positive things, I know Boston is a great healthcare center, but they have social workers to work with cancer patients. And I think that would be an excellent thing that we could do here, because it certainly helps with mental health. And obviously, when someone has cancer, that's a very important aspect to look at. I also had a son-in-law who lives in Canada, and he had a liver transplant 9 years ago. So if he was living in the US, he would not be alive today. So we do have a lot to be thankful for. Some of the things I had mentioned in my card earlier was that I think we should work more on preventative health care. I'd like to see more nurse practitioners. I was a nurse myself many years ago, and back in the 70s we were talking about nurse practitioners, and only now they're starting to implement them. I'd like to see better access to our general practitioners. Unfortunately, sometimes when we're sick, it's a week or 2 weeks before we get to see somebody, and then you're almost ready for hospital if you're really sick. So I think if we could have better access to our family physicians, we'd be a lot better off.
Thank you. Was there a question you wanted to ask?
Not really, just those comments.
I appreciate that. Okay. It's interesting talking about the United States. One of the issues in the research for our forum that we came across that is actually from the United States, and I'm not sure if it exists here, but I'm anxious for somebody in the panel to let me know. In the United States, some states have reduced costs by using physician assistants, and my understanding is a physician assistant is basically someone who goes to med school and does the first 2 years in some states, but doesn't graduate and gets licensed. Does anybody know much about physician assistants? Okay, good. I shall come over here then. Capture you. Yeah.
What I'm about to say is probably old.
Old?
Okay, it's not current necessarily.
All right.
But I know that the genesis of physician assistants were in the military, and that was when paramedics they took the keenest and the brightest and trained them because they needed to use them on site at the site of
battlefield. A
battlefield, yes, exactly. And then when they retired, like the Vietnam War, and they all came back, and they all had such skills that then they got molded into physician offices. And it's a very good model, and in fact, if it's still happening, which up to a few years ago it certainly was, in Manitoba they were leaders and they had have physician assistants, if it's still the case, working in the operating rooms and the emergency rooms and others. So it's advanced now. The training is different because there's no battlefields in Canada to train physician assistants. But that's the way it has been. And I would see that that's a wonderful role to assist.
Okay, so some hope for physician assistants. Also, one of the other things we've discussed tonight are what are those other jurisdictions that we can actually take some examples from that might work. One controversial one is in Quebec, where I know this because my brother's a doctor there, and his partner in medicine has a Visa and Amex cards because he specializes in certain diagnostics, which in Quebec you can pay for, get the diagnostic done, and it'll actually push you further in line for the surgery. Arguments against it are, of course, you're jumping the queue. Arguments for it, you're allowing more people to get surgery quicker. I see that you want to jump in here, so I shall come over here and try to get you.
Okay, thank you. I just wanted to make a couple of comments.
I'm not proposing.
Okay. Thank you, Lynn, for your comments. I wish your daughter the best of luck with her cancer treatments. So for 15 years, I worked here at Memorial University at the Student Health Center. It was an incredibly rewarding practice. And of course, because of our dwindling birth rate, Memorial University is actively recruiting internationally. And so I had quite a few patients who actually came from the United States to do their master's and their PhD program. And once they stayed in the province long enough, they switched over to MCP. And they thought MCP was wonderful. Compared to the healthcare system that they didn't have in the United States, they thought this was absolutely wonderful to be able to access it here in the province. So even though it's not ideal, you know, I think it is good that we can offer the same healthcare to all and everybody here in the province. The second thing I wanted to say about Memorial University is Dr. Peter Cornish, who heads up the Counselling Centre, developed a stepped care program for mental health, and that has been adopted by the province of here, Newfoundland and Labrador, and was recently launched this past winter. And that's an online resource that patients can go online, access on their phone, on their tablet, and do this stepped care program for their own mental health.
All right, thank you. Ramona.
I am here with Janine Hubbard, who is a psychologist, and I can't wait to hear what your issue, comment, or question is.
I really have a two-part comment, and it reflects some of the comments that have been raised so far this evening. But from the perspective of psychologists, the extreme importance of early assessment, early diagnosis, and early intervention amongst our kids, whether that's for mental health issues, whether that's for learning issues, developmental issues. We know that if we can get in early, we can prevent those long-term chronic issues from developing. The second piece...
Wait, can I stop you there? Yeah. So how are we doing on that in this province?
We've got a ways to go, for sure. There have been some nice initiatives, and we're going to be really curious to see what comes out of a couple of the task force committees that are currently underway, because I know that's one of the things that they are looking at is ways to get that happening at an earlier stage. So fingers crossed, and we're going to stay tuned on that. The second part is more on the adult end of things, looking at those primary health care teams. We know that in places like Ontario, the embedding psychologists on those teams, partly to deal with mental health issues, but to help deal with the chronic health issues, to help deal with the chronic pain while you're waiting to see the rheumatologist, to help manage lifestyle issues around managing your chronic diabetes. All of those things can work in partnership.
So just to make sure that as a layperson I'm understanding correctly, so if I'm in a lot of pain and it's chronic, I could become depressed or anxious? Is that what you're talking about?
You can do that, but psychologists are also able to teach you pain management techniques to help reduce your pain levels and help get you more functional. We can't take your pain away, but we can't take away the underlying causes, but we can work really hard with you to get you to a more functional state where you're experiencing lesser levels of pain and feeling more functional.
Okay, does anyone care to respond? All right, Dr. Dwyer.
So yes, certainly, we are looking at developing primary care health teams. So we're groups of family physicians with all our allied health, whether it's nurse practitioners, social workers, psychologists, we'll be working together. Certainly in Ontario, where that's been done, where they've had collaborative teams, and so there's so many patients that are attached to that team, so it improves access for patients. And yes, they do have psychiatrists, but the models that I have heard, unfortunately, the psychiatrist has been paid for by the regional health authority, and that's why they're contributing to the group. They're not actually part of the group, but yes, it would be very beneficial to be able to do that. And yes, with respect to chronic pain, we know that patients who live with chronic pain on a day-to-day basis, they are at high risk of developing depression just because of the chronic pain that they are living with.
All right, Anthony.
All right, I have a comment here from Facebook. I believe Barry Moores writes, in the Deloitte report that was released last summer, he knows this stuff, government has indicated it will introduce a new individualized funding, or IF, system for the disabled. This will supposedly introduce a single point of access to provide more control for the disabled and lowering costs in the regional health authorities' financial divisions. What do your experts think of this new policy, and has the amalgamation of health boards 15 years ago benefited or harmed the delivery of health care in the province, in their opinions? So we'll see which one of you would like to tackle that. Debbie, you look tempted.
I can't comment on the program that he references because, quite frankly, I know nothing about it. But in terms of the amalgamation of the regional health authorities, it depends on who you ask, what day of the week, whether it's been a benefit or not. There's no doubt that amalgamation of health boards has consolidated some services, has allowed provision of services to be done more efficiently in many ways, but it's also created challenges. And I think some of the challenges came around not supporting the amalgamation with the right resources when they all came together. We still, many years later, still have policies that are not consistent, for example, all across Eastern Health. So if you look at a policy on X, which might be in place at the health sciences, that same policy is it's not the same policy, say, in Clarenville, and it's the same employer. And in order for all that merging and that to happen, you needed to have supports and resources. But the boards were expected to merge and just save money, just like that. Like, you're going to merge and save money. And that doesn't happen. If you've ever gone through that type of process, you know you need to invest, things like change management. How do you educate people and what it means and all of that? How do we get policies the same? And that investment wasn't done. You know, I think for a lot of people, they would say it was a backward move, but I think in terms of efficiencies, eventually we'll get there, but we're not even there yet, and we're many, many years beyond when the amalgamation was done.
Okay, Debbie, I have a feeling that you might be involved in the next answer as well. Marie Strang, what would you like to talk about?
I just wanted to say that I am a registered nurse. As registered nurses, we have a specialized body of knowledge. We're very knowledgeable about many things across the lifespan. Recently, our union has launched a campaign called More Nurses Can Save a Lot. And as in healthcare, as in anything else, things are based as evidence-based. I'm just wondering, Debbie, if you could speak more to the evidence that surrounds that more nurses can save a lot.
What is that?
Well, absolutely, and it was a campaign that we started because we feel that we're spending money in healthcare where we don't need to be spending it, and by investing in registered nurses, we can actually save money. And some of the examples that we used was the significant amount that we're spending on overtime and sick leave, and the magnitude of over $45 million a year, which is a lot. Where talk about access to surgeries and surgeries being done on time. In Eastern Health, in 1 year, they actually canceled 300 surgeries because there weren't enough registered nurses to care for patients post-operatively. So it's not just a physician you need, you also need the other providers down the line. And research shows when you invest in registered nurses and nursing, that will actually save the system money. So for example, it will prevent falls and infections and those things in the elderly. Surgical patients, if you have the care of a registered nurse, and by adding one patient to the care of a nurse who's working on a surgery unit beyond a certain amount, actually increase the risk of that individual dying. So there is research to show if you have the right staffing levels, you will actually save the system money by prevention. And if you know the work of a registered nurse in our acute care system, but also in long-term care and community, we're all about prevention because we prevent C complications before they happen. So if you're that patient who comes out of surgery, it's the registered nurse who is monitoring your symptoms. It's the registered nurse who recognizes, you know what, your blood pressure is dropped. You don't look as well as you did an hour before. There's something going on here. And it's the registered nurse who calls the physician and says, you need to come look at this patient because this is happening. I know it's happening because of all these things. And then something is prevented. That's what we do every day in the healthcare system, but we need the people to do it.
All right, Anthony.
Well, fewer than 5 minutes left in our critical condition forum here at the Bruno Centre. I want to get to some comments that we haven't touched on tonight. Of course, healthcare is such a vast subject, it's almost impossible to get on all of it. But Cara O'Keefe on Twitter writes, let's not forget the role that pharmacists can play in bridging primary care gap. They can prescribe for a variety of minor ailments and extend or alter prescriptions, but the government will not reimburse these services and push the cost onto patients. And June Taverner writes, I run a private nursing company and it's not illegal to take advantage of private clinics. The clinic itself has to be careful not to infringe on the Canada Health Act, but most don't. In fact, mine focuses on ensuring the public healthcare system and it remains sustainable. So some of the comments that we're getting online as we wind down our forum here at the Bruno Centre. Ramona.
Let me put a question to Dr. Susan King and Dr. Susan McDonald. If you want to chime in on this one, you're more than welcome. Clearly, we don't have a lot of time here, but I'm wondering, we just heard a pitch for pharmacists to be able to prescribe more and to have that more widely available. It's available now, but people aren't paying those fees. How do you feel about that as a doctor? Do you feel territorial? Because if we're going to fix the healthcare system, people have to kind of give up their perches, don't they, that they're sitting on?
Well, yes, we have to rethink a certain hierarchy that tends to exist, and just we're all working together to improve the care of our patients. In answer to your question about the pharmacists, they have a lot of skills. They know a lot. They know an awful lot. I phone up pharmacists many times and ask her, what drug should I give next? Because I don't know what to do, et cetera. You have to be careful because they have to assess a patient and they have to have a certain other. They're not trained in the diagnosis model. They're trained in the medication, and safe prescribing and safe use of medications. So it's a tangly one, but the pharmacist is a resource that we all appreciate because they're the most accessible. You walk in off the street and there's a pharmacist that you can ask a question about anything in your health and they can help you out.
Definitely. Anthony.
I have a comment here. It has to do with the diagnostics we're talking about. Nellie Wall writes, I'm wondering why some diagnostic services are not contracted out to avoid long wait times. For example, in Alberta, one can have a mammogram at 10 p.m. and not have to pay for it. Some of our diagnostic services close early and expensive equipment is used only for a small portion of the day. Interesting observation. I wonder if somebody here would like to talk about that. All right. It's the Debbie Forward Show.
Doctors and nurses duking it out.
Yes, with respect to diagnostic services, I believe that the Janeway is, their CT scanners being used after hours for adult tests. I can't speak specifically to mammograms, but I guess, again, are we getting into that after hours, or are we looking at independent clinics that would be setting up? So I'm not quite certain what you meant by that question, whether we just keep our facilities that we have open longer in the evenings, but that comes down to a staffing. If, you know, the breast screening program is located at Major's Path, but that's an Eastern Health facility, so it would mean keep paying the staff to keep the facility open longer.
All right, and let me give Debbie forward. That was just a little joke about duking it out. Let me give you a very quick opportunity to respond here.
Well, they have expanded some services, but you also need the people to administer the test. And it's hard to recruit those people, and they're costly. So in order to, you know, to run your CTs longer, you have to have staff that, you know, the staff working the day, and then you need an evening shift. So that's double the staff, double the recruitment, making sure people are trained. So it's not just the machine, it's the people that go with the machine. So we can't forget about that. If it was all about machines, it would be simple. You press a button, but you need people to provide the test, and that is where we run into challenges around recruitment of those technicians in particular.
All right, so Anthony, do you have a comment that you wanted to get in there just before we wrap here?
I do. Jill Bennett writes, I can tell you what works wonderfully in the healthcare system, the palliative care unit, including the public health team. They are the most attuned, helpful, caring group of people I have yet to meet at the hospital. Dr. McDonald is doing high fives. Too bad diagnostics wasn't as swift or helpful. It would have saved my loved one from currently needing the palliative care unit. So rather poignant comment there coming from Jill Bennett. Well, I appreciate everybody who's written in this evening, and of course, a special thanks as well to our audience here at the Bruno Centre. I think it's been an interesting night, and I really appreciate now Ramona does, because Ramona and producer Jen White, who's over there, they really are the masterminds, along with all the technical people who helped them put together our critical condition series. So it really is thanks to them. It winds down. I think we have another piece tomorrow by that guy sitting over by himself over there. So there's one more item, right?
Our colleague Ryan Cook, well,
Yeah.
he's here. He's assigned to this, so he's going to be reporting on this. And don't forget, Health Minister John Hagee will be interviewed on the St. John's Morning Show. So that is happening, I believe, between 7 and 7:30 tomorrow. And for those people who are viewing from other parts of the province, it is entirely possible that your local CBC Radio Morning Show will pick up that interview.
And on television, as far as Here Now goes, we hope to play some of the highlights. Lots of stuff to chew over and try to share with the audience tomorrow on CBC television as well. And of course, none of this would be possible without our panelists who are here. So for all of you, perhaps get a round of applause, because it's quite an evening.
Indeed. Thank you so much to our panelists. Thank you to everyone who came here tonight. Huge thanks to Memorial University for making this venue available to us. We couldn't do it without Memorial University. And Anthony, we can't sign off without an enormous round of thanks to our technical crews, right?
Absolutely.
They've done an incredible job here. Yeah, the unsung heroes, as usual.
Thank you very much, and we'll see you tomorrow on television and on radio.
All right. Thanks so much, everyone. Good night.
Bye now.